And our next speaker is going to be Dr. Bilal Hameed. Bilal, first of all, I'd like to thank you for bringing Paul into the family. You've been a branch that we reached out to, and that turned out to be a real tree. You know, Nora and Paul, and I just can't imagine what other gems you shall be bringing from California next. You've turned out to be a whole tree, and I would say an almond tree, because Californian almond trees are so good. And, you know, almonds make us smart. So I think Paul is a big almond, and so are you. And Dr. Bilal Hameed, for those who don't know, and he's a regular with us, he's authored a lot of peer-reviewed articles. He's a member of the NAFLD, the AGA, and the American Society of Transplantation. And he holds a fellowship in GI and hepatology. And he's currently serving at the UCSF, where he's serving as a transplant hepatologist. He shall be speaking on the evaluation and management of NAFLD. For those who aren't aware, who are still stuck in the days of HPV and HCV, NAFLD is the biggest cause of liver transplant in the world. Dr. Bilal, you may take the stage.
Of what we discussed early in the morning about the prevalence and the HCC risk and other thing, and so we're going to talk about as a case-based discussion, and these are my disclosures. I'll kind of skip that because of the time reason. Let's go to the case. So this is a patient, Mr. Khan, who's a 49-year-old, fatty liver for many years, and based on an ultrasound. His ALT is 85. He has history of type 2 diabetes, obesity, and dyslipidemia. So he's asking us the three simple questions. How severe is my liver disease? What is my outcome? And how will you manage my condition? This is the same thing we see every day in my fatty liver clinic. And I'll try to address these questions and see what answers we will gonna get. So some of the earlier information that we had that the fifth ward did show that he had advanced fibrosis, and transient elastography showed he has a KPA of 10. So he has like F2, F3 fibrosis. So when we talked about earlier in the morning, we all know that NAFLD is a progressive condition, and about 70% of patients who have NAFLD, then 20-30% will gonna develop what we call NASH in America. It's about 15 to 30 million people. And then these patients, out of those, 25 to 30% will have advanced fibrosis, will lead to portal hypertension, 20% will have HCC, and then liver failure, and 2 to 3%, 3 to 5 per year of HCC. So one thing we all know that based on the studies that fibrosis progression, one stage is about 7 per year. But then there are patients who have rapid progressors, that they can progress 20% over 10 years to cirrhosis. And there are some of the risk factors that we know that are associated with NASH progression. So overweight or obesity, type 2 diabetes, if you have metabolic syndrome, 3 or more features, dyslipidemia, in America at least ethnicity, and there are some more genetic factors that are coming up. Sedentary lifestyle or Western diet, polycystic ovarian disease, obstructive sleep apnea. Other thing is, if you have a first degree relative with NASH cirrhosis, also can have a higher risk of it. So if you have a patient who is 50 years of age, greater than type 2 diabetes and first degree relative, that is the strongest clinical predictor that this person will have a progression of NASH and fibrosis. So this is the study I showed earlier. This is our New England Medical Journal article from NASH CRN, where we have about 1,700 patients, which was followed for about median follow-up about 4 years. And the point which I wanted to bring it again is the fibrosis is the most important determinant. If someone has F4 or cirrhosis, not only they had other liver-related complications of variceal bleeding, ascites, hepatic encephalopathy, and HCC, but death from any cause or overall mortality was significantly increased because of when you have advanced fibrosis. Now, this is a simulator that has been developed by MGH, and I've started using it recently. This is a paper which was just published earlier this month. And it is available online. You can download it. They have the simulation model. So this is a 49-year-old patient, and they talked about what is their risk based on the fibrosis. So if you look at it, if someone has stage 4 fibrosis, not only their risk of liver-related mortality, but extra hepatic mortality is significantly increased. And if you put that patient that we just saw, 49-year-old, and based on these models and based on the data, that about 13 years if someone has cirrhosis and 21 years. So this is a pretty significant change in that. Because problem with NAFLD is that you don't have any symptoms. And patients are not worried about that they have. So we need to talk about it and clarify, especially based on the fibrosis, what is the risk of progression and outcomes would be. And this is again, in the bottom, if you have F4 fibrosis, look at the mortality. It's significantly improved over 20 years. So I started showing this to my patients and I have seen significant improvement in their thinking about what they understand about their condition, and they start paying more attention to their health. So, as I mentioned earlier, NAFLD is a silent condition. Majority of patients that we see are asymptomatic. There are some patients will have right upper quadrant pain, but fatigue is also very common, and sleep apnea because of the way the chicken or egg thing, which one comes first, but like 40% will have sleep apnea. And ALT and AST may be completely normal in about 55 to 60%. And a lot of patients actually ask us, like, how can you say that I have any liver disease? My liver enzymes are completely normal. And that's also a problem that we see, that patients are not referred to us if they have normal ALT, and that's an important factor that primary care use. And it may be associated with other conditions. Ferritin can be elevated in NAFLD. We see secondary iron overload. At the same time, one thing, when we do all the blood tests earlier, there's a nice lecture on autoimmune hepatitis. The smooth muscle antibody can be seen up to 20 to 30% of patients with fatty liver disease, which is not part of autoimmune hepatitis. And 8% of patients can have elevated antimitochondrial antibodies. So, it is also some of these autoimmune markers are common in fatty liver disease. So as I mentioned about the reliability of liver enzymes, normal liver enzymes are seen in about 50 to 60% of patients, but about 60% of patients with advanced disease can have completely normal ALT. So we cannot go with fatty liver diagnosis or severe just based on the ALT. This was a study from the VA system. What they actually looked at the data of about 251 patients, and they tried to identify which patient got actually referred. So they look at the primary care note, about 39% there was a mention of abnormal ALT, and just the ALT was the main reason patients were referred. And out of those patients who were referred, some of them 3% already had advanced fibrosis. So again, we need to educate our primary care physician, we need to educate the community about this disease, and also about that ALT is not a only factor that we look at it. We need to look at other factors, and I'll talk about the algorithm that we use to identify patients who are at the highest risk of fibrosis and who need to be seen by a specialist. So let's talk about the diagnosis, what we have available. So what things we need to know? Is fatty liver present? Thus my patient has advanced fibrosis. And also never forget about the other key organs. And on my next talk, when we talk about the holistic approach to fatty liver disease, I will discuss more about these end organs. But when we see a patient, we need to talk about what their heart is doing, what their kidneys and pancreas, their diabetes risk, and we need to address at the same time. So this is the ASLT, AGA, and ACG guidance that, if you have hepatic steatosis by whatever means, right, whether it's ultrasound, CAP, MRE, or if you have a biopsy with no other significant alcohol consumption, no competing etiologies, no coexisting, you can label someone with fatty liver disease. Now, I know that someone will be asking the question, what about NAFLD versus MAFLD, right? That is a big point of discussion. And NAFLD is right now a diagnosis of exclusion. You need to exclude everything. You need to exclude alcohol. And metabolic associated fatty liver disease are recommended as a new name by 2020. It was discussed about. It was a diagnosis of inclusion, that you have fatty liver and you can have other conditions. So in Europe, it became a lot of interest, and Americans was also behind, and we would say NAFLD. So interestingly, there was Mary Ranella led that. It's a consensus conference started by ASLD, which a lot of, EASL, Latin America, BASL, they all. It was in early July, and the whole discussion whether we should change the name. And in the end, consensus still is up there. There will be another meeting that will keep the name for NAFLD at this time. So that's why you will see the name. And the reason it's very easy, that, you found out your child name and someone tells you it's not the right name, you wanted to change the name, you can start calling your child that name. But when you go in, you have to change it every other place. So what they realized, that all the effort we made, because all the clinical trials, everything that's going on is based on NAFLD definition. If you change it, we're going to move the field many years back. So that's why I think there's a lot of legal things, a lot of other things, and it will change the definition, whether it will be NAFLD or something else. But right now, NAFLD is still the ongoing name that you will be using in all the clinical trials and all the publications coming forward. So when to use the imaging to diagnose NAFLD, there is no formal recommendation, but we consider in about signs and symptoms if you have hepatomegaly, elevated liver enzyme, but someone with diabetes or multiple metabolic. The Diabetic Association has actually changed their recommendation to start screening for NAFLD. ASLD new guidelines likely we're going to update that. Right now in ASLD, the guidelines still say not to screen. Ultrasound, there was a question that asked, is still the easiest, inexpensive, the best way to diagnose hepatic steatosis. And it is also very good to test. However, when the fat is less than 20 to 30%, it may not detect it. The technology is improving, but ultrasound is still very good. Also, it is technical dependent. MRI PDFF is the best technology to detect any amount of fat, and it's most sensitive even as less than 5% or around 5% of the fat. It's also been validated in the studies to follow the changes in if you wanted to follow these patients on treatment trials or any lifestyle intervention. The problem is the patient tolerability and cost. They are working in about 5 or 10 minutes MRIs in the future, and the cost is going to come down, but right now it's still not available for everyone. The important thing that has changed significantly is this simple and that clinical laboratory test. We talked about FIB-4. I'll show you some data. NAFLD fibrosis score, I like both of them really well. And this complex scoring system, and this is not a complete list. There are other compounds, but ELF, which has recently got approved by, and it's made by Simmons, has gained a lot of popularity. And I think that will gonna also change. And there's some HEPA score and liver fat scores. And the imaging wise, you have transient elastography, MRE elastography, and chair wave elastography. So let's look at some of these things, how you proceed with it and how you check your patients. So when you look at the clinical prediction rules to identify fibrosis, NAFLD, which has three components of age, ALT, AST, platelet count, BMI, albumin, impaired, blasting score, and FIB-4 has only 4. The age, ALT, AST, and platelet count. Use anyone, these labs have been available in majority of the time and anyone can check it. And now in our electronic medical record, the FIB-4 automatically gets generated easily. So if you have the new system would be, the lab can give you FIB-4 as soon as they get the lab done, and that will be the future model for many electronic medical record systems. It is sensitive in excluding advanced disease. The performance does vary by age. So if you have advanced age like greater than 65 years of age, the test may be falsely elevated, less accurate in diabetic, so they have something that you have. And the VRE, vibration control or transient elastography is very accurate in detecting steatosis. It predicts the risk of decompensation and very reliable in ruling out the advanced disease and very widely available. The MRE is also become very, very popular, and we are using more and more MRE because we have the availability, but still the cost is it, and it can detect very good amount of fibrosis, it's not dependent. And this is some of the features that you see. In the red, it's basically fibrosis, and blue, you don't have normal. And you will see a lot of these new phase 2 clinical trials using MRI-PDFF or MRE as technology, and it has some role in it. However, in countries like Pakistan and other third world countries, not going to gain the popularity as easily. These are some of the comparison of imaging biomarkers, but what I can say that transient elastography can be done very easily. And it can be a, point of care testing that you can also do it, and cost is much cheaper than compared to other technologies. So how do you design a referral pathway, right? It has to be based on evaluation of fibrosis. It has to be easily accessible, calculated automatically, so you don't have to worry about it. It has to be inexpensive and have to have a very high negative predictive value. So the AGA, actually Fasiya Kamal, which is one of our faculty member who comes and, proud, editor of our journal, CGH. She was the first author on the gastro. This is the AGA, some of the guidelines. And it looks like very simple, that you have these risk factors, you exclude the causes, And the first thing is that we check FIB-4 scores, and then divide patients who have low FIB-4, and which is basically low risk if you have less than 1.3. In those patients, you just repeat it in about 2 to 3 years' time, and then you have indeterminate, and you have a high-risk group. And the high-risk group, you go into the next step. And there are different technologies, and this will gonna change the more and more non-invasive markers we will gonna have. ELF has been added to we have this as more. And now this is the EASL guidelines for, non-invasive testing. And again, using the same thing. Use the FIB-4 scan, then you go to the liver stiffness and decide which pathway to go from and identify patients. Now, we also still doing a lot of liver biopsies, but likely liver biopsies are going to go away. For the clinical trial, we're still requiring liver biopsies, but hopefully in the future, the non-invasive testing will be using even for deciding which patient will going to need treatment. So lastly, in the last, I'm going to go quickly about some of the management about fatty liver disease. And it's a major public health problem that does not have any adequate treatment. So the goal of treatment, when we see a patient, the 49-year-old patient that we mentioned, that we wanted to reverse the fibrosis. If someone has NASH, we want to reverse the NASH because it's an important determinant of fibrosis. But at the same time, we need to improve some metabolic health. So we cannot focus as hepatologists just on the liver. We need to make sure that we talk about their obesity, type 2 diabetes, and dyslipidemia. So these are just some of the management options that we're controlling obesity, reducing cardiovascular death, and targeting NASH and cirrhosis. And when you look at this AGA guidelines, this also talk about that which patient will be discussing about how to move forward. And you're going to see that the GLP inhibitors have been coming more and more. And there was an excellent talk by our endocrine expert in the morning about the GLP inhibitors, agonists about that. So the pharmacotherapy is only needed for patients who have advanced fibrosis and also with NASH, right? We don't talk about the pharmacotherapy in patients who just had low risk for fatty liver disease. We talk about all the modifiable risk factors, and this is very important to focus on it. EASL has a very nice lifestyle changes, but this is based on the European, right? We have to adapt what is easier available in Pakistan. But we have these simple recommendations about the low calories. What I talk to my patient about low calorie, low carbohydrate diet, and also about alcohol is a big part of it in America, and we have to talk about how much alcohol they're drinking, and especially if they have fibrosis. Coffee is good for the liver, but it's a black coffee, not with sugar and all the milk that we talk about. So, reality, the Mediterranean diet has gained a lot of interest, but reality in our Western diet that we think about the Mediterranean diet, but what we eat is completely different, right? And it's very hard. And in America, in Pakistan, the diet is even more that available, all the diet are there. But the most important diet is what the patient can afford and maintain. Because even in America, the healthy diets are very expensive. And so we need to talk to the patients about what you can do. We have nutritional specialists. We talk about it, but it's very hard. The weight loss has been talked about consistently that you have improvement, but we also have seen that this weight loss achieved in these very established clinical trials where you have these patients monitored very closely. But the problem is that if you look at it, majority of patients gain weight. And so the diet, no matter what diet, we have studies from diabetes, very hard to maintain. And therefore, most of these patients require medications ultimately. We talk about bariatric surgery has excellent data out there, although most of them are retrospective. But the resolution of NASH can be seen in about 84% of patients, even 5 years after the surgery. And fibrosis improvement can happen up to 70%. So there will be selected patients who still will be candidates for bariatric surgery still considered. Now we talked about the pharmacotherapy, but only used in patients according to AASLD for biopsy-proven NASH, and same with the other guidelines are suggested. So only selected group of patients who have NASH with fibrosis will be candidate for any pharmacotherapy. I'm going to skip that. We have So currently available pharmacological compounds are all off-label. These are not. The two that have been talked about is pioglitazone, which has its own effect because of the weight gain and heart issues. And vitamin E has been shown in one of the studies with our, from the NASH CRN. Arun was the first when the vitamin E versus pioglitazone was used in biopsy-proven NASH and the decrease in the NASH score. 43% of patients on vitamin E arm had improvement. It does not guide towards the fibrosis, although this was 800 IUs per day. We just started a clinical trial from the NASH CRN that we're using 200, 400, 800 versus placebo and does not need a biopsy, just an ALT elevation. So hopefully if that shows, the vitamin E still have some benefit, but we wanted to see whether that will kind of sustain or whether we can show consistent improvement in different dosages. Lastly, I just wanted to give you that picture. This field has been growing significantly. Every day there is a new compound for NASH that is coming, different phases. However, despite more compounds coming in, majority of those has failed and that bridge has not been crossed so far. It's a valley of death, but these are some of the compounds which are in the phase 3. There's one other one, the GLP-1 and glucagon just started the phase 3, which is not there. The semaglutide injectable is in the phase 3 and there are oral agents, and I'll talk a little bit about it, hopefully my talk on Sunday. But semaglutide, I just wanted to mention, has seen a lot of publicity. It's already approved for weight loss and diabetes. This was their phase 2 clinical trial, 72-week study of 320 patients with stage 1 to 3. It has 3 arms of the study. And if you compare that, semaglutide 0.4 milligram had NASH resolution with no worsening fibrosis. Although it did not show improvement in the fibrosis, but when you compared the placebo versus semaglutide, the placebo group had progression of fibrosis as compared to semaglutide, which has stability. So it is very exciting. The semaglutide has some effect. And this Mounjaro or terpizidine, I think that will kind of likely take away bariatric surgery, and this has been more and more has been used. If you look at the weight loss this medication is causing, it's so impressive. So these are very promising agents that are out there that hopefully for diabetes and the weight loss can also help with the fatty liver disease. So in summary, over the past decade, we had made significant improvements to advancement to understand NAFLD. We have a much better idea about the pathogenesis, natural history, and outcomes. The non-invasive testing and care pathways have been established but need more refinement. But therapeutic and drug development has also been getting better and better. But the fibrosis development continues to be the most important determinant of progression of liver disease and mortality. The non-invasive scores can identify patients which are high risk and need to be seen by specialists. But the goals of treatment remains the same. We need to resolve the NASH, which is the strongest predictor of fibrosis. We need to improve fibrosis, which is the strongest predictor of mortality. Although we don't have any FDA-approved therapy right now, but the future is very bright. My hope is in the next 1 to 2 years, we will have FDA-approved medication for selected patients with NASH with advanced fibrosis. This is the end of my talk.
NAFLD is just about as challenging as grabbing your attention post-lunch.